Hi, everyone. Don't know if you recognize the room. Hope you've been able to enjoy your day off a little bit. This is a lecture that we would have gone over really briefly in lab, but I'm going to go over in more detail since we're not meeting this week. And then next week, my plan is we may have our models and bone samples, and we will kind of combine the labs of the 2 weeks so that you can handle the specimens in the lab. So let's get started. We're talking about the skeletal system. And so in this unit, we're going to cover tissues that have functions like holding skeletal structures together, things that separate groups of structures, things that provide support, protection, and storage. So there's our functions, and all of these tissues fall under the connective tissue category. So we're going to see that they have cells and that they all have an extracellular matrix, and that is made up of fibers and ground substance. And it's going to be different. Those three substances are going to be different depending on the tissue type. So in this section, we've got hyaline cartilage, compact bone, and spongy bone. Remember, this tests are not cumulative. So when you see histology for this unit, these are the things to keep in mind as tissues that we're going to have looked at. So first, let's look at some hyaline cartilage. It is a connective tissue that's made of chondrocytes. Chondro is the prefix for cartilage. So we've got our chondrocytes, we've got collagen fibers, and then a semi-solid extracellular matrix. And it's got a lot of water in that extracellular matrix, and then those collagen fibers are covered in chondroitin sulfates to give it this unique texture. Cartilage is avascular, does not have a blood supply, which makes healing really slow, and is one reason why once arthritis appears, it's really difficult to get any healing in that area. We see cartilage, hyaline cartilage, in the embryonic skeleton, the end of long bones, where it's called articular cartilage, articular having to do with joints. We see where it connects the ribs to the sternum, known as costal cartilage. The word costal will always have to do with the ribs. And then also in the nose, the trachea, and the larynx. And the functions are to support and reinforce. It makes up cushioning structures and reduces compressive stress. So we have a sample of tissue here from the trachea. Don't look at this tissue. This is not what we're interested in over here on the left, but we're interested in this hyaline cartilage on the right. It's surrounded by a perichondrium, peri meaning around, and you can see the chondrocytes. They are in little individual cavities called lacunae. You can see their dark nucleus, and then they're surrounded by that extracellular matrix, this light pink color. I recognize them because I can usually see the lacunae pretty clearly. And for me, they look a little bit like a cat eye. That helps me to recognize that we're looking at hyaline cartilage. We're going to be looking at compact bone. So compact bone, it's a solid connective tissue. The cells here are called osteocytes. They too are found in lacunae. And we also have collagen fibers. We've got some calcium salts and some calcium carbonate. And we need the collagen to give strength and resilience. In diseases where their collagen is lacking, the bones are so brittle they can't withstand any force, but we need the minerals for the hardness and rigidity. And the bone tissue is deposited in layers called lamellae. So each little circle here is called an osteon. That's kind of the smallest grouping of bone cells that we have. You can see these little dark areas are your osteocytes. Inside their lacunae. And then you can see the circle layers, kind of like an onion. They are the lamella, so the concentric layers there. And then we have a central canal that has the arteries, the blood vessels, and the nerves. It's also known as the Haversian canal. It is well vascularized, so that's a difference from cartilage, and so it heals well after a fracture. It's found in all bones. It's that hard external surface. This is probably what you think of when you think of bone. And function-wise, it's going to support and protect. It's going to provide a lever system for the muscles. It stores calcium and fat. It also contains bone marrow, which is the site for blood cell formation, also known as hematopoiesis. So we've got compact bone, and that is different from spongy bone. Spongy bone, also a connective tissue, but it's less dense than compact bone. Still made of osteocytes, but instead of having those circular lamellae, we've got these trabeculae, which are bony spicules that make a mesh-like network, kind of like a sponge, hence the name. And then in between the trabeculae, you've got red bone marrow. You're going to provide nutrients, help remove waste, and then that's where the blood cells are produced through hematopoiesis. We see this at the end of long bones, in the ribs, the skull, the pelvic bones, and the vertebrae. And it's to provide structural support and flexibility. It's got metabolic activities, and it's that site for hematopoiesis and the production of bone cells. So looking at this, you can see here the trabeculae, kind of the little spicules or the mesh-like network. And then you can see the bone marrow inside. Bone marrow has a pretty high fat content. You hear people talking all the time about bone broth. Well, it's rich in iron because the bone marrow is that site for red blood cell precursors, and then it also has a fair amount of fat. And so these white areas are areas where the fat has not stayed on the slide for the staining and preparation. And so maybe another little tip, I guess, if you're looking for a way to identify. Notice you do have some pink background like your cartilage, but the cells are much less dense. And again, this spicule kind of spongy appearance is unique to spongy bone. So a long bone, let's think about the bones of like our femur or our humerus. We've got compact bone as the dense outer layer that strengthens and resists compressive forces. And then spongy bone is in the epiphysis in the end, and it's offering support and flexibility with that open network. And then you have articular cartilage made of our hyaline cartilage that's at the end of the bones at the joints, and it's reducing friction and acting as a shock absorber. So looking here, a couple of terms you want to be aware of. So we've got the diaphysis, that's the shaft of the bone, and then your epiphysis, and that's the ends of the bone. Epiphysis have your spongy bone in them, and then your diaphysis has yellow bone marrow within it. If we're looking at the epiphysis, we can see spongy bone, deep. We've got a layer of compact bone around that, and then the articular cartilage in the joint to reduce friction and provide support. And then if we look in the diaphysis, here we can see really nicely our osteons, those lamella, that compact bone. And we're still seeing the vasculature that's prominent in bone, helps it heal, helps get the nutrients to it, and removes waste. So I recommend spending some time making a little chart that's showing the similarities and differences between bone and cartilage. Think about the cell types, the fiber types, what's the matrix, what does it do? These are great ways to keep them straight, and also questions that could show up on the exam. We're going to look at the axial skeleton as well. We're going to start with the skull. But first, what are the divisions of the skeleton? You've got two parts. You've got your axial skeleton and your appendicular skeleton. So the axial skeleton is made of the skull, the vertebral column, and the thoracic cage. Think about it, those things that go along midline. And then your appendicular skeleton is your arms and legs and what attaches them to the axial skeleton. So your pectoral girdle, kind of in your shoulders and your clavicle, your upper limbs, your pelvic girdle, and then the lower limbs. Recognize the pelvic girdle is not part of the axial skeleton, even though it's on midline and kind of seems to be part of that central support. It is technically of the appendicular skeleton. You will be learning in lecture a little bit about the shape of bones, but you want to be able to give an example of each shape and identify each shape. So long bones, we talked about those in the histology section, but the length of the bone is greater than the width, like in the femur, the humerus, or the tibia. In short bones, the length and the width are about equal, and they sometimes look kind of cube-shaped. So that's your carpals and your tarsals. Flat bones have really thin plate-like structures. Think of your sternum, your ribs, and your parietal bones. And then irregular bones have irregular shapes. So your vertebra over here, your facial bones, the pelvic bones, all irregular in shape. This image also includes sesamoid bones. These are bones that are found in tendons usually. So we're looking at a little patella or kneecap here, another type of bone to be aware of. So there are various words to describe the different projections, depressions, processes, openings in the bones. And you're going to be seeing these as we go through. I'm not going to stop and describe them all to you, but you want to know all of the bones of the skeleton. And then there are some bony markers and structures that will be in your lab manual and in your PowerPoints and the new lab manual activities that you'll be responsible for. So looking at the skull, we're looking at the anterior surface, things we want to be aware of. We've got our mandible here, that makes up the lower part of the mouth. And then we have our maxilla, the purple. I remember the maxilla because there could be a guy named Max that has a mustache, and it would be on his maxilla. You've got your zygomatic bones, these teal colors. Those are your cheekbones. You also have the frontal bone of the forehead. You have parietal bones, which are along the side of the skull. And then your temporal bone is just peeking out around the corner where the temples are. A few other bones, we've got the sphenoid bone, where you can see it here as well as here in the back of the orbits. We're going to be seeing a lot of that bone. It is butterfly shaped and it appears lots of different places on the different views. We also have the nasal bones paired up here. And then we've got the vomer. This is one of the unpaired bones that is at the lower part of the nose. A few landmarks you want to be thinking of. You've got your mental foramen. So the word mental has to do with the chin. So mental foramen is on the chin. You've got a supraorbital foramen or a notch. You've got some blood vessels and nerves that come in that area. And then you've got your orbit here. So that's where your eye is. And we definitely want to be aware of the bones that make up the orbit. A few other highlights while we're looking. You've got your lacrimal bone, this green one. The word lacrimal has to do with crying. So lacrimose is a fancy word for crying. I remember it's right here, the center of the eyes, or where the tear would come out. And then you've got your ethmoid bone behind that, and we'll see the ethmoid bone. Even here, we can see a little bit of it in the back of the nose. So if we look at a right lateral view, here again, we've got our mandible and our maxilla, our nasal bone, that one tells you where it's at. You've got your frontal bone and your parietal bone. Parietal is on the side. The new bone here is the occipital bone in the back of the head, and we're able to see the temporal bone more clearly. Notice that there is a zygomatic process of the temporal bone, and that connects to the zygomatic bone here. You can see your lacrimal bone where those tear ducts would be, and then your ethmoid bone here, a little deeper in the orbit. Once again, we've got that mental foramen to keep track of. We've got the mandibular ramus. Ramus means bridge, so it bridges the mandible to the rest of the skull. You've got the styloid process. This is a good structure to remember. It is very distinct when you see it. I kind of remember it's the super pointy one, and it can act as a great landmark. As you know, and as you'll see when you get the skulls, when you have them in a different orientation, sometimes it's hard to figure out what is where, and that for me is a real starting location. You've got your mastoid process. It's usually a little bit lateral and caudal to your styloid process, much rounder here. And then your external auditory meatus, that's where your ear is. We want to know about that. And then this is also showing us some of the sutures. So sutures are joints, but they're joints that don't have any motion in them. So we want to know the different sutures. Your coronal suture. Remember, we talked about the frontal plane could be called the coronal plane. So you've got your coronal suture. You have your squamous suture, which goes between that temporal bone and the parietal bone. And then you've got your lambdoid suture here between the parietal bones and the occipital bones. So be aware of those different sutures so you can identify them. Here we are at a posterior view, one more suture to add, the sagittal suture between the two parietal bones. We've got these little sutural bones. That just means they're small pieces that appear at the sutures. They can vary from individual to individual. And then definitely be aware of your occipital condyle. That is where the skull rests on the spine. So we'll be talking a little bit more about that as we go. This is an inferior view with the mandible removed. So a couple of new bones for us. Here's that maxilla again, but we have the palatine bone, which is on your palate. Here's that vomer again, and we're seeing the pink sphenoid bone. We've got the occipital bone and the two temporal bones here. Just so you're aware, these pictures are from your Pearson textbook. They have great images, and there are some really nice quizzes for the Pearson homeworks. If you're doing those homework assignments where you can match things, great opportunities to study. So a couple of things we want to know here. We want to know, once again, here's that styloid process, the pokey one, and then here's the mastoid process, lateral, a little bit posterior, a little rounder. You've got, again, your occipital condyles where we're going to sit on the spinal cord. We have here the jugular foramen, so that's where the jugular vein is going to go, and it's just a little posterior to the carotid canal, so be aware of those. You've got your external auditory meatus, where your ear is, and then also your stylomastoid foramen, which helpfully is right between the styloid bone and the mastoid bone. Your styloid process and your mastoid process, so stylomastoid foramen. For me, I'm not worried about the nuchal lines. I'm not really worried about the occipital protuberance, but those definitely styloid and mastoid. Remember your jugular foramen, your carotid canal, your auditory meatus, and that stylomastoid foramen as well. You've got a couple of others here. You've got your foramen ovale, which is in your sphenoid bone, and then your foramen lacerum. When you look at the models, you'll notice this one is really rough and looks like a laceration, hence the name lacerum. And now we're looking inside. So we've taken the top of the skull off and we're looking where the brain would sit. So we've got the frontal bone. This is our sphenoid bone. Again, we've seen it in lots of the different images. We've got let's see, these are the temporal bones. And then here is the parietal bone and the occipital bones. Few things to point out here. This is the sella turcica. It stands for Turkish saddle. It looks like a little saddle, and that's where the pituitary gland is going to sit. So you do want to know about that sella turcica and what sits in that gland. Also, you want to know about the cribriform plate. So this is where the nerves from the olfactory system, from the nose, connect with the brain. So this is in the ethmoid bone itself right here. This is why, if you have ever heard of the neti pot, still is popular and is effective if used correctly. For a while, people would put water and salt in it, and then you'd pour it in your nose and kind of inhale and get some of the saline up there, and that would help loosen any mucus in the sinuses and help with congestion. However, some people used water that was not sterile or boiled and came right out of the tap or came from like well water, and they put it in their nose, they sniff up that water, and if there were any amoebas or any little critters in there, they would actually crawl through the holes crawl through the holes, well, it's an no too, but crawl through the holes on that ethmoid bone to get into the brain, if you've heard of the brain eating amoebas. So if you're using anything up your nose, make sure that it's the sterile saline that you get from the drugstore, or that you've boiled it really effectively. So the skull is divided into two sets. You've got your cranial bones and your facial bones. Cranial bones enclose the brain. Facial bones form the face, the eye socket, the part that we think of as the face. And they're joined by those sutures, which are immovable joints, and only the mandible is attached by a movable joint. So there's 8 bones of the cranium. All bones are single except for 2 paired bones, so the parietal and the temporal bone. So we're looking at the cranium. First of all, we've got the frontal bone here. We've got our forehead, the superior part of the orbit. And internally, the anterior cranial fossa, we want to keep in mind that supraorbital foramen or the supraorbital notch. We've got the parietal bones. So here are our parietal bones. We've got the sagittal suture that's running on the sagittal plane, and then as well the coronal suture where it's going to articulate with the frontal bone. We've got the temporal bones where we have the inner ear. It's got the squamous suture. It's got the zygomatic process, and that comes off of that temporal bone to join that zygomatic arch, the cheek. It's got a mandibular fossa, so it's a depression on the inside of the zygomatic process to form the socket for the mandibular condyle. Let me zip back here so we can see that mandibular fossa. So it's right here. It looks just like the mandible is going to fit there. And again, a little bit lateral to that styloid process. So mandibular fossa, where the mandible goes, your external auditory meatus, and then that styloid process. We've got the temporal bone. We've also have the mastoid process that we've talked about. If you have inner ear disease, if you get like infection, it can get into that mastoid cavity, and then you've got big problems because you don't want it to go to your brain. If it goes to your brain, then you're going to get meningitis as it affects those meninges. So don't let your ear infection sit. Make sure that they get treated appropriately and follow the directions your doctor recommends. These are some of the things we've talked about these, the squamous suture, the lambdoid suture, there's that zygomatic process, the auditory meatus, and the temporal bone. We've got the occipital bone. We've talked about that. It is the posterior cranial fossa and the back wall of the cranial vault. We talked about the lambdoid suture, the foramen magnum, foramen meaning hole, magnum meaning big. It's the big hole, and it's where the spinal cord goes to the brain. We've got the occipital condyles that allows the skull to articulate with the first cervical vertebra. And then you've got your carotid canal, which is where the carotid artery can go in to supply blood to the cerebral hemisphere. So here's your carotid canal. Those are some structures to be aware of. Your sphenoid bone, bat-shaped, butterfly-shaped, whatever helps you remember it. It forms the anterior plateau of the middle cranial fossa, and it connects to all other bones of the skull. Once again, some cocktail trivia for you if you need it. It has the optic foramen. You can see them. Sometimes you can't see them as well because they're kind of hidden under here a little bit, but those are jagged openings into the orbits. You can see here with like the optic canal, where the nerves associated with the eye, the optic nerves go. And then here's that sella turcica, and it's specifically the hypophyseal fossa, holds the pituitary gland. The fancy name for the pituitary gland is the hypophysis. I'm not worried. You can call it the pituitary gland. We've got the ethmoid bone. It's an irregular bone attached to the sphenoid. It's the roof of the nasal cavity, the upper nasal septum, and the medial wall of the orbit, And then the cranial nerve 1, the olfactory nerve, passes through that cribriform plate for the sense of smell. So here's that ethmoid bone, just so that you can kind of see. When I see it out of place, I just remember it's the one that looks really spongy with a lot of holes. I am not worried for you to know the different parts of the ethmoid bone, but this is a great image of those olfactory nerves that are going through the ethmoid bone directly to the olfactory bulb of the brain. Here's the nostril where the smell would enter, or the odor would enter. So there's 14 bones composing the face, and 12 of them are paired. So the mandible and the vomer are the only single ones. And various bones of the cranium and the face will make up the eye socket. So you want to know these 7 bones of the eye socket. Let me see if I think we'll have an image of them in a little bit, but we want to know those. You've got your mandible, which is your jawbone. It's got the movable joint with the temporal bone. You've got your mental foramen, and there are some nerves and blood vessels that go there. This is a place, if you go to the dentist and they numb your mouth, they're going to use some of the nerves and blood vessels that come out of this area. And then you've got your mandibular condyle, which articulates with the mandibular fossa. Here's that mandibular condyle, so you can be aware. Here is that mental foramen, so you know where that is. Here is the coronoid process. I point this out because we're going to be seeing some coracoid processes. So keep track if it's a coronoid or a coracoid. Your maxilla, they're fused in a median suture, and they're the upper part of the jaw and the lower part of the orbit. And all the bones, except for the mandible, join the maxilla. So it's called the keystone of the face. You've got your infraorbital foramen, so that's this little spot right here, and you've got nerves and blood vessels to the nasal region of the face. If I go back a little bit, you should be able to see that infraorbital foramen right here. Wild veterinary story for you. With the infraorbital foramen in a horse, you can actually see that blood vessel and take blood samples from the blood vessel. But in the horse and cow, more than that, you can use that vessel to numb part of the face, and using other locations where you can put lidocaine or numbing agent, you can do eye surgery with a cow that's not completely sedated. They'll have that eye completely immobilized and numbed. They won't feel anything, but it's all because that infraorbital foramen you can see fairly well. Lacrimal bone, small bone, medial orbit wall between maxilla and the ethmoid. Right here, the little green one. Please note, don't learn the colors. The colors are not going to be the same on the test. If you just remember the bone is the green one, I'm sorry, you'll be disappointed. We've got the palatine bone. It's a paired bone, and it forms the posterior hard palate and is part of the inferior orbit. Another veterinary connection, there is a disease with if there's an abscess behind the eye, and you can have patients come in with like their eye all red and goopy and looking not well, and one of the places you're supposed to look, and you should look, is you open the mouth, and occasionally they will have gotten a stick stuck in the back of the mouth or stuck in this tooth. It will have kind of gone near this palatine bone and allowed the infection to get in the eye. So your treatment is you sedate the animal and you drain it and use some antibiotics, and the eye will heal up very nicely. So that helps me remember that the palatine bone is associated with the eye, because who would have thought you needed to look in the mouth when there's a problem with the eye? Zygomatic bone are your cheekbones. Zygomatic process comes off of the temporal bone to connect to the zygomatic bone, forms a lateral portion of the orbit. We've got those two little nasal bones at the bridge of the nose. You've got your vomer, the little blade-shaped bone. It forms the posterior and inferior portions of the nasal septum. And then we've got here a picture of a baby skull. You will notice that the sutures are really visible. When the baby is being born, it has to fit through a very small opening. And so skull is not completely ossified. The sutures are not completely hardened, which allows a little bit of movement there to facilitate the birthing process. And then over time, those sutures will harden. But you also have what's called fontanelles, which are the soft spots. So we want to know the fontanelles. There's an anterior fontanelle. There's a sphenoidal fontanelle, kind of by the sphenoid bone. And then we've got here a mastoid fontanelle, again, kind of back here, maybe where that mastoid process is a little nearer. And then the posterior fontanelle. So these are the soft spots. You can, so if for little dogs, if you think of like the little chihuahuas that have the really round heads, you can sometimes feel their soft spot. And for patients with really bad hydrocephalus, if their soft spot's still open, they can even put the little ultrasound probe on it to see part of the brain. Fortunately, they close up as the baby ages in humans, and so we don't have to worry about that too much as we get older. So here are some blank images that you can use to quiz yourself to see if you've mastered some of the material and are understanding things. Got a little bit of space to practice, and then we'll go on to the next section. It's a new day, and we're ready to go for the rest of our axial skeleton. So looking at the spine. The spine is also known as the vertebral column, and it extends from the skull to the pelvis, and it's the major axial support mechanism of the body. It protects the spinal cord. It allows for passage of the spinal nerves between the adjacent vertebrae. And it's made up of 24 vertebrae and 2 composite bones being bones that are fused. So you want to know how many vertebrae are in each section of the spinal cord. So there's cervical vertebrae, there are 7 of them. There are 12 thoracic vertebrae, 5 lumbar vertebrae, 5 sacrum, and 4 coccygeal. And you can see we label them. So C1 is the first cervical vertebra. So keep those in mind, know those numbers of the vertebrae. Excuse me, little mnemonic, if you want to remember, excuse me again, think about your meals. You eat breakfast at 7, you eat lunch at 12, you eat dinner at 5. And then in between the vertebrae are intervertebral discs. And these have a central fluid-like nucleus pulposus and an outer ring of collagen, kind of stringy fibers known as annulus fibrosus. And when people talk about having a bulging disc, this is what they're talking about. I kind of think of it like a jelly donut, and sometimes a little bit of the jelly is escaping from where it normally should be and causing irritation to the spinal cord itself. So as you age, the water content of the discs decreases. So they're harder and less pliable. They're not quite as soft. And so the outside, the annulus fibrosus can tear, which allows that nucleus pulposus to kind of move out. Here is the spinal cord right here, and here that nucleus pulposus is pushing on your spinal nerve. So you're getting some pretty significant pain there. People talk about having discs fused. That means that there's not any pressure to continue pushing out that nucleus pulposus. People talk about resting when there's a disc. You know, if you rest, you decrease that inflammation. So maybe there's less swelling that is causing that compression. In animals, they do surgery where they'll actually go in and kind of use a little surgical vacuum cleaner to suction up this nucleus pulposus that has escaped, or remove some of the vertebrae that could be causing that pressure. So the discs and the spine's natural curves make it a good shock absorber. You have thoracic and pelvic curves that are present at birth. So here is your thoracic and pelvic curve, and then your cervical and lumbar curves develop later. So know when those develop and what directions they go. And the cervical and lumbar curves develop partially as a result of gravity and us standing and moving around. So abnormal curvature is going to be something like scoliosis, which is where it's going laterally. So the spine deviates right or left. You can have kyphosis, which is where you have a really pronounced thoracic curve or a hunchback, or you can have lordosis, where you have a really pronounced lumbar curve and then kind of a sway back. And these are abnormal, and over time, you're not distributing your weight normally. You're distributing it abnormally on your discs, and you can start having some issues. So here are some pictures. We've got an image of some pretty significant scoliosis here on the left. And now this is being addressed by having these vertebrae fused in more of a vertical midline pattern to help reduce abnormal stress. So the vertebral structures, some of these are common to all of the vertebrae. So you want to know these, you want to be able to identify them. You have your vertebral body. So that is the part right here. That's where the disc would sit. It's the biggest surface of the vertebra usually. You have your vertebral arch. So the arch makes the arch itself. And then you've got your vertebral foramen, and that's where your spinal cord goes. So the vertebral arch surrounds your vertebral foramen. You have your transverse processes, and these extend laterally from the vertebral arch. But you also have a spinous process that extends usually posteriorly. And I think of this like a stegosaurus has spines that come out. Our spinous process is where those stegosaurus spines would be. You have a pedicle. So your pedicle is right here, and it's where that vertebral arch is attaching to the vertebral body. You've got your lamina. So that's the upper part, or the more posterior part between your spinous process and your transverse process. And then you have superior and inferior articular processes. So here is the superior, and we've got some inferior as well. It depends a little bit on which part of the spine we're looking at, but this is where the vertebrae connect with each other and where they will articulate. And then you don't see it here, but there are also intervertebral foramina, and that's something we want to be aware of. Intervertebral means it's between the vertebrae. So not only do you want to know the parts of the vertebrae, but if you're given a vertebra, then you want to be able to tell which part of the spine it's from. So this is a cervical vertebra. We know C1 and C2, these are atypical, so we'll look at those separately. And C3 through C7, they have similarities. So how do I know this is from the cervical spine? Well, the first thing I look at is the spinous process. So if you notice, this vertebra is rotated, actually flipped. So we've got the posterior here, and then the anterior here with the body. So in cervical vertebra, you've got these short spinous processes, and they are bifid, so they are actually divided in two. So that's one way to notice. And then you have these transverse processes. They're really short. They're not long like we'll see in other places. And then my other super special one to remember is these transverse foramen. This is where your carotid artery will go through. And so only cervical vertebrae have these. And then they're going to have the smallest body. They bear the least amount of weight. So I look first to see, does it have the transverse foramen? What does its spinous process look like? And then kind of check out the other factors to see, can I recognize it? C1 and C2 are atypical, so they're known as the atlas and the axis. So the atlas is what sits right underneath the skull, and that's where these occipital condyles will articulate. So if we look here, you've got these parts of the atlas where your occipital condyles will sit. Your spinal cord's going through this opening. Atlas comes from the mythological hero Atlas, who supports the weight of the earth. If you've heard of the book Atlas Shrugged, and if you've ever been to Rockefeller Center, they have this guy holding the earth on his back. That's Atlas. And in this image for the body, the earth is like our head, and Atlas is holding it up. And then C2 is the axis, and the really prominent feature of it is the dens. So we can see the spinous process here, but it has this protrusion called the dens, and the dens sits right inside here on the atlas, and there's a little ligament that helps hold it in place. And that allows us to turn our head and say no. So again, our atlas, no vertebral body. We've got anterior and posterior arches. We've got lateral processes with these huge articular surface. And this is what's going to allow us to nod yes. So the atlas is for yes, and it's the only articulation. It's really unique between the atlas and the occipital condyles. Notice again, we still have the transverse foramen, so that should help you know this has to be somewhere in the cervical spine. The axis is C2, and it's got this process called the dens, or the denser odontoid process, and it articulates with the atlas, and it's what allows us to say no. So again, when I'm looking at vertebrae, I'll look and see, does it have the transverse foramen? If it does, I double check the spinous process. If it has that, I'll kind of look and see, is there a dens poking out somewhere? So we're seeing here how the atlas and the axis sit together and fit. There's the dens that is sitting within the part of the atlas. Thoracic vertebrae, there's 12 of them, and they are bigger than the cervical vertebrae. So the body has two little articular facets on each side for the ribs. So we don't have ribs in the cervical spine. We don't have those facets there. And then the spinous process is really long, and hooks downwards. So if your spinous process is not protruding straight posterior, it may be a little more likely to be thoracic. The articular facets will articulate with the transverse process, or excuse me, they will articulate with the tubercles of the ribs. So we've got transverse processes here. Remember, those extend laterally, but there are facets on the end of those for the ribs to articulate with. And then they form the posterior aspect of the rib cage. And only thoracic vertebrae articulate with ribs. Other vertebrae don't have an articulation with the ribs. And here again, you've got your body and your spinal canal that we want to be aware of. The lumbar vertebra, there are 5 of them. They are large block-like bodies. When I look at a lumbar vertebra, I kind of look at it and I say, is the body just huge? It almost looks like a big rectangle. It's really thick. It has short and thick spinous processes. So if we look here, here's our spinous process. Here it is again. It does angle a little bit inferiorly, but not nearly as much as the thoracic vertebra. The articular facets are oriented differently. So we can see those here. And they receive a lot of stress, so they have to be extra strong. The spinal cord ends at L2, but we've still got covering beyond that because there are nerves that continue beyond where just the spinal cord ends. And we've got our sacrum and coccyx. So the sacrum is 5 fused vertebra, articulates with L5 superiorly and the coccyx inferiorly, and then articulates with the ilium on the lateral surface, and that's the iliosacral joint. The coccyx is 4 or 5 fused vertebra, and it's the remnants of the tail, which was seen embryonically. Things to look at, you've got these dorsal foramina here. You have your sacral ala. So ala comes from the word for wing, and it does look a lot like a wing. And you have sacral horns, and those are the superior articular processes. Looking at your thorax, so we finished the spine, we're looking at the thorax, and we've got 3 big parts: sternum, the ribs, and the thoracic vertebra. So we've talked a little bit about the thoracic vertebra, and the thorax has costal cartilage. Costal is the word that has to deal with anything with the ribs, not dealing with money, but dealing with the ribs. So costal cartilage is in the thoracic cage. You have your sternum, which is 3 fused bones. So you have your manubrium most superiorly, and it's got a little notch where your clavicle is going to articulate with it, a notch where the jugular veins are going to come through. You have the body, so that's the main part of the sternum that we think of. And then you have the xiphoid process. This is where if you're going to give somebody the Heimlich maneuver, you kind of want to be going in that area. Also is a landmark surgically for, where you might be making an incision. And for the ribs, we have 12 pairs of ribs. Please know how many ribs they are. And they all articulate posteriorly with thoracic vertebra. They connect to the sternum with costal cartilage. So this kind of lighter white material that we're seeing, that's all costal cartilage that's connecting those ribs to the sternum. Ribs 1 through 7 are true ribs. So they're known as vertebral sternal because they connect almost directly to the sternum through that cartilage. Ribs 8 through 12 are false ribs. They're called vertebral chondral because they don't connect directly to the sternum. They have some cartilage that connects to cartilage that connects to the sternum. So there's kind of a little cartilage intermediary. And then ribs 11 and 12 are floating ribs. So they don't connect to anything at all. They're otherwise known as vertebral ribs. So you want to know which ribs are true, false, or floating. Realize false and floating are very different terms. So keep track of which one is which. We've got the structure of a rib. We've got the articular facets that are going to connect with the spine. We've got the angle, and then we have a sternal end here as well. And there are some tubercles for muscle attachments. And that's where we're seeing a little bit of a tubercle here. So you've got your lab activities to use. Don't worry about that for right now. Do the lab activities that you have in your lab manual, as well as visible body and updated lab manual. Those are your big focuses for this week. And then I will see you guys next week So that's, let me tell you the date before we go. So I'm going to see you guys on the 23rd. To continue doing the appendicular skeleton. Reach out if you have any questions. Hope you have a great day, morning, evening, whatever it is for you right now. Bye.